Good afternoon. We had a sudden change of plan for the last case. Our initial idea was to show a 7-year follow-up of a dedicated drug-eluting stent for bifurcation with degradable polymer, the DVAC stent. A patient that was treated in 2004. The patient was in hospital to do the procedure, but at the last minute, he said that he was not quite sure he wanted to go for another catheterization. Although I must tell you that in the past 6 months, he was symptomatic with stable angina. But he said that he would like to think about, he didn't want to go for the live case demonstration. He didn't want to do it today. So we accepted. We can't do anything different. You know our way of work. And we decided to show the baseline procedure and the protocol, the 6-month follow-up. That's what we're going to do now. But in the meantime, I will show, I'm in the Cath Lab 3 where we were supposed to do the case. As you can see, it's empty, the patient's not here. And I will show you the case from our Cath Lab 1. In the meantime, I will make a quick tour around our institution. We have 6 Cath Labs, Cath Lab 4, Cath Lab 6, Cath Lab 5.
That's real life.
Come with me, Cicero. Cicero is our cameraman today. He will follow me. Kaká is saying goodbye. Cicero. Kaká is saying goodbye.
Oh yeah, bye-bye, Kaká.
And we are moving to the
There's a
Cath
lot
Lab
of wires
1.
there.
We are supposed to show from there. Here, just a moment, Cicero. I want to show then our storage room where our material is kept. Every time we need something, we ask them to take it here, as you can see. One more room, Cath Lab 2.
There is another room for the storage room as well.
Yep. Here is where our stents stay, the shelves where they stay, as you can see. And I'm just getting to the Cath Lab 1 where everything is going to take place. To present the case, I will give the microphone to my colleague and brother, Ricardo Costa. He will present the case. He took part in the case 7 years ago, at the time as a fellow.
Thank you, Jose. Hi, Alex, Roxana, and everybody. We have here this interesting case. If I could have the image here. So this was a patient, a 70-year-old male. As a risk factors for coronary artery disease includes hypertension and dyslipidemia. At the index procedure, he had an Assenssement Biodegradable A9 dedicated bifurcation stent for the circumflex lesion. So this is the lesion, as you can appreciate, so involving the mid portion of the circumflex. Here, once we stop the lesion, and just to tell, I cannot hear you back, so I'm just going to present the case here. We have the lesion here involving the proximal, mostly the proximal part of the circumflex. In the distal vessel, so here basically the distal branches, they have pretty much the same size. And we have also a significant involvement of the ossea of one of the branches here, if you want to name it a side branch. So basically a significant involvement of the proximal part and ossea of one of the distal branches, and no significant involvement of this branch here. 2 branches were wired. There was a predilatation of the side branch here. And this is also already the positioning of the dedicated device, the Assenssement. So this is a 7-French compatible system. As you can see here, I'm going to stop the image. So the system has some markers. This is the proximal marker in the proximal end of the stent. This is a distal mark in the distal delivery system itself, so it's not the stent. We can see the stent here, and this is the distal mark of the distal end of the stent. So at this point, you can pull, you can retrieve partially the sheath that contains the self-expanding device. And it's very important to see that in the distal end here, you can see flaring of the system, of the stent distally. So at this point, you can still pull back or push forward a little bit just to have the proper, the optimal, the accurate positioning, as you should have these markers within advancing into the distal branches. So after advancing, as you can see here already, we have the markers in both distal branches here, and we're performing kissy balloon inflations. And this is the final result. You can see optimal result, and with good scaffold of the osteum of the distal branches as well. Here we can see in the RAO caudal view. So again, highlighting here, so you see the osteum of this distal branch with a good scaffold. One marker here, positioned here, and two markers positioned in the other side, and the proximal marker. Yeah, in the spider view, we can see again. So this patient returned for 6-month angiographic follow-up.
Stop there a little bit. Leave that image. Leave the image so I can explain using this factoid here. So this is a self-expanding nitinol stent with a zigzag design, as you can see. So you start to deploy distal and before you get to the carina. When it gets to the carina, it flares, it's open up. So then you push forward a little bit. So that's why you cover the two often, the main branch and the side branch. And when you do need an additional stent, and then you go ahead and put one or two legs. So, but this is very didactic here, so you can see how it works and what Ricardo showed with the radiopaque markers inside the two branches. So you really create this new carina with access, with two wires, access to both branches if you need to stent either the main branch or the side branch. And that's what you saw there. Ricardo, you don't have much time. Can you show us the final result? 15 minutes to show the last case from Dr. Kambara.
Absolutely. So I'm just going to show you the image of the final result and then the 6-month angiographic follow-up. The result is well sustained. This is an IVUS image of the device here. It's a bioluminescent, so it's minimal intimal hyperplasia. And this result was sustained at 6 months.
So I think one of the reasons why we chose to show this case, I think it's first of all because it's a dedicated stent, so by itself it's interesting. But recently, a company called Biosensors acquired DVAX, and they are developing now particularly a dedicated stent to treat left main bifurcation, which I think it's going to be, a great solution. And we wait for the Excel perhaps results, and if it's positive as we believe it will be, I think this is going to be an interesting solution. So just perhaps a few comments from the audience, perhaps Ari or Hugo Londeiro would like to make a comment before we go to the other room.
Hugo.
Okay, I think that we need a dedicated stent for the bifurcation, and this is a good possibility like Capella. Yet it is not covered with the drug, but I think that we need a drug-eluted stent for bifurcation.
Julie, you agree with that?
And I think that the auto-expandable, self-expandable stent will be probably better than balloon expandable in this situation.
Great.
So bifurcation is a challenge, a problem for us, interventional cardiology. So any solution you try to do, and so I think it's possible in the near future you'll have some data about this new dedicated stent.
Okay, yeah. So perhaps 3-4 minutes for Jose to show the final result of the left main case that Fausto did this morning. And also if you want to give the microphone to Fausto for final comments, because that was a very interesting case that generated a lot of discussion. So if you can show us,
Okay.
Jose, please.
Okay, Cicero, please, from the... Okay, you have the angiogram from the room 1?
Yeah, we can see it.
Okay, that's where falls to left you when the transmission was out. He had just implanted the stent in the LAD, and as you could observe at the time of the deployment, there was a little jump of the stent. The stent moved ahead, moved forward. And there was this gap
So we
here.
missed the ostium, right, Fausto?
Yes, that's perfect. Rivamar, if you can go just three pictures back, we are going to see the position. That's very important. Three pictures back.
Backward.
Back.
That's the picture.
Okay, one more, please. One more. Yes, no, that's it, yes. When we were really in a hurry at the time, that was not perfect, correct, like I really like, but we were in a hurry, and we thought we were in a perfect position at this time. Could you, yes, loop, yes. We thought we were at the perfect top technique. Next, when we inflate the balloon, if you look at this, I could feel that, but I don't know. Next, we did not have time to say, just jump on 1 millimeter, and I missed the ostium. I was really disappointed with this. We just prepared the circ, we did kissing, as you can see here, and when we went to the, this view looks good, but when you go to the other view, we left you with this one. So we took the third stand, this is a 3.0 by 16 millimeter, and next. Okay, so we went up to, this is 3.5 balloon. That's a 3.0 in the ostium of the circ. We took a 4.5 balloon before IVUS because we measured by QCA, was almost 5.0 left main. That's a 4.5, so just expanding at the left main. Next. That's a 3.0, the kissing, 4.5 and 3.0. We also worked a little bit distal to the LAD. Next. So the patient was stable. We had the impella device there. This is a 4.0 balloon in the mid portion of the LAD because we thought we need to work a little bit more on this vessel. Next. Okay, this is the final result. And I'll leave the Rivamar with the word because we're going to show the IVUS image if we have time, Alex. Maybe 1 or 2 minutes. It's very interesting. It's up to you.
You know, it's such a beautiful angiographic result that I think if we go to the other lab, Fausto, if you don't mind.
Okay, no problem.
10 minutes for Cambada, it's not fair.
Rivamar.
Thank you. This was excellent, and I think that's very honest to bring back and show.
Before giving the word to Cambada, I want
there's
to...
no time to show the IVUS, I'm sorry.
No, we're not going to show the
other
IVUS. We're going to show the patient, Senor Oséias, that he wanted to say how he's feeling after this procedure this morning.
A todos o meu cordial bom dia, e em especial à equipe médica.
Thank you.